thank you all for coming today. My name is Amanda Potasnik, and this is Taylor Gall. Today we're going to be talking to you about the effect of weight change on standard uptake values in positron emission tomography. At the end of this presentation, the audience will be able to recognize the clinical significance of standard uptake values, identify how cancer treatments can affect a patient's weight, and observe and evaluate changes and patterns of standard uptake values and weight changes. Standard uptake values are defined as the percent of radiotracer uptake by a tumor versus a patient's background, and they provide radiologists with supplementary practice to visual image interpretation and can also give them a semi-quantitative assessment of cancer processes. Standard uptake values have been the subject of numerous research studies regarding the usefulness of these numbers and their diagnostic aid in the field of medical imaging. In many cases, standard uptake values have provided diagnostically useful information to classify lesions based on size and tracer uptake. It can also provide information on if a tumor is benign or malignant. And these values have many factors involved to affect their calculations, such as age, height, weight, blood glucose levels, dose, and the total length of the exam time. Heavy research has been conducted on the variability of these numbers and the factors to determine if any trends or discrepancies exist. However, little research exists on the effect of patients' demographic information and their calculation of standard uptake values. And on the screen displays the formula for the calculation of standard uptake values. K sub I represents the net rate of fluorine-18 fluorodeoxyglucose phosphorylation as a measure of tumor glucose use, and it is proportional to the activity concentration in the tissues divided by the ratio of the injected dose divided by the patient's weight. And this number is equal to the patient's SUV.
Weight-based change, in particular, is a common occurrence in patients receiving subsequent PET scans after chemotherapy or radiation therapy. Weight change may potentially be one of the largest variables because of its direct use in the calculation of standard uptake values. Weight change is essentially an inevitable occurrence in many patients after therapy. Body weight correlations can be classified as a weight gain or a weight loss, and it differs based on the initial body composition, their gender, their metabolism, and their type and extent of cancer. The volume of distribution of fluorine-18 fluoro-2-deoxyglucose depends not on a patient's body weight, but on their body composition. Patients who are considered obese tend to have noticeably higher SUVs for malignant tumors because the concentration of F18 FDG in adipose tissue is substantially lower than that in the rest of the body. Consequently, the distribution of F18 FDG volume per kilogram of body weight is reduced in obese patients when compared to leaner patients. Standard uptake values normalized to the patient's lean body mass or body surface area has led to more accurate and reliable estimates of the F18 FDG metabolic rates in obese patients.
This research will address the effects of weight change in the fluorine-18 FDG oncology patient on standard uptake values across multiple imaging sessions. And this research was completed through a retrospective analysis of both initial and subsequent PET-CT scans. So the researchers retrospectively reviewed 10 patients from the Washington Hospital in Washington, Pennsylvania, using a General Electric Discovery ST16 slice PET-CT scanner. Both imaging sessions were processed by using GE Dimension software versus version 2.6 after reviewing patient demographic information to determine a patient population. And the criteria used to determine the patient population was based on oncology patients of either gender who underwent at least 2 subsequent PET-CT scans. In order to obtain the most accurate results, the subsequent imaging sessions were only chosen if they were 1 year apart or less, and a weight change of plus or minus 10% was required during that time period. The patients ranged in age from 46 to 78 with varying cancer types and treatment options. Some of the diagnoses included esophageal cancer, tonsil cancer, lymphoma, and a number of various cancer types. Treatments varied from chemotherapy, both chemotherapy and radiation therapy, surgery, or no treatment. And Washington and Hospital PET-CT protocol was followed, so patients were injected with a target dose of 15 millicuries. The residual activity remaining in the syringe was measured so we could determine the actual dose that the patient received. The patients were instructed to try to fall asleep for 1 hour in the uptake room to allow for even distribution of the tracer. And following the uptake period, images were taken from the top of the patient's eyes to the bottom of the patient's thighs, usually between 5 and 7 bed positions. And once the patient population was determined, the researchers reviewed the 2 subsequent PET-CT scans and calculated the SUVs using the GE Dimension software. SUVs were calculated over the patient's primary and/or most prominent cancerous lesion, and the researchers tried to replicate the dimensions of the patient's tumor. So the researchers then calculated the change in weight and SUVs of the subsequent PET-CT scans using the equation on the board, initial minus subsequent divided by initial times 100.
For confidentiality purposes, the patients were not referred to by name, but by numbers instead. The patient number corresponds with each other on every table and graph. The table represents a summary of the data obtained during the course of the study. It summarizes both the initial weight in kilograms and SUV and the subsequent weight and SUVs. This table shows the change in weight in kilograms and the percent weight change. The range for weight loss was between 9.1 kilograms to 20.4 kilograms, while the range for weight gain was between 8.6 kilograms and 18.7 kilograms. The percent weight change varied in weight loss from 14.1% to 26.4%, while the weight gained varied between 10.8% and 22.8%. The changes in the standard uptake values ranged from negative 12.9 to positive 2.0, and the change in the percent of standard uptake values ranged anywhere from a decrease in 79% to an increase in 46.5. For supplementary visual assessment, this table was provided to easily compare the percent weight change and the percent SUV change. These are calculated by a gain or a loss. The first table shows the patient disbursement with weight change in respect to the treatment had. The treatments varied from chemotherapy and radiation therapy, surgery, or no treatment at all. The second table shows patient disbursement of weight change and standard uptake value changes. Only patient 5 had a weight increase and an SUV increase, while patients 3, 6, and 9 had a weight increase but an SUV decrease. And patients 1 and 10 had a weight decrease and an SUV increase, while patients 2, 4, 7, and 8 had a weight decrease and an SUV decrease. This graph provides a visual display and compilation of data disbursement between each patient's percent weight change and percent SUV change plotted as an X and Y coordinates. As shown on the graph of percent weight change versus percent SUV change, the results showed no direct correlation between a patient losing weight or gaining weight due to therapy.
And after reviewing the data as a whole, there seemed to be no direct correlation between a patient losing weight or gaining weight due to therapy between the subsequent imaging sessions. However, similar patient populations yielded similar results. I'm not going to go into too much detail, but for just a brief overview, all 3 patients below the age of 50 showed a direct correlation between weight change and SUV change. This was indicated in patients 2, 5, and 8. And patient 2 and patient 8 displayed weight loss of over 10% and had a decrease in SUVs that seemed to result from their weight loss due to therapies. Both patients had chemotherapy and radiation therapy. And patient 1 and 2 lost weight and had a decrease in SUVs, while patient 5 had an increase in weight and an increase in SUVs.
This research showed no definitive findings or direct correlation between the weight change and standard uptake values between subsequent PET-CT scans. Considering the results, there are many fluctuations in the data due to the patient age, patient metabolism, type of cancer, treatment type, gender, and the patient's lifestyle. This research may have been more accurate and complete if the researchers were able to collect a patient population of all the same type of cancer to make the results more statistically significant. The research could have also been more complete if it was done across multiple institutions with different PET-CT scanners and processing software. This would lead to less variations in the results, and in addition, the small sample size only represents a subset of the population that needs to be studied. Further research is needed on the effect of weight change on standard uptake values. And we would like to thank the Washington Hospital, which includes Mr. Ralph Willem, Ms. Jennifer Getze, Dr. Timothy Zelenak, and Dr. William Castro, as well as Dr. William Wentling, Dr. Angela Macy-Byers, and Mrs. Donna Mason. And these are our references. Any questions?
With regard to your sample size, you only had 10 patients, correct?
Yes.
Is that because you could only obtain records for 10 patients? Or is that because there was only 10 patients that were significant to your study?
It was difficult to find a patient population that fit the exact criteria because we needed weight loss or some form of weight change of at least 10%. If you think of your weight, and some patients needed a weight loss in less than a year time period, maybe a couple months, so they needed to lose 10% of their body weight or gain 10% of their body weight during that time period and have some form of treatment for their cancer during that time. So it was difficult to find patients and evaluate that in that form of aspect.
What might you have hoped to gain in this type of a study? Like how weight gain affects treatment, or how doctors might treat somebody due to a weight gain or loss because of the various treatments that they're undergoing? What would you hope to gain from the result of this type of research?
We're looking more so at the validity of standard uptake values to determine how they exactly change. So each one is calculated for a patient's particular scan. So we're seeing exactly how do these values change? Are they statistically significant? Is this for something we should be using in the future? That we should be looking at patients' tumors with standard uptake values to determine if this is something that is really of use for patients. Thank you.